All right. So
Well, I love it how you put John Yarmouth's quote right
Wait.
next to Donald Trump.
Well, this is, we're,
Well-
we're live now. Larry.
he loves it. It's okay. So some of this is a hodgepodge of things that aren't necessarily from the articles that I send, but they're things that I've seen that I have trouble thinking about and like how I would explain, especially this first quote from the CNN article about how Medicare payments only covered 87% of the costs in 2016. That was from the American Hospital Association, but the private insurers paid 145% of policyholders' expenses, and that was sent to me by the AMA's representative at U of L saying that this is how, this is where everyone's position is right now about single payer. So I was kind of confused by that. I also looked up that number and I couldn't find it anywhere, even when I went to the American Hospital Association website. And it wasn't linked anywhere, so it was confusing to me.
Just logically confusing because they paid 100% of their hospital expenses.
Yeah. Well, yeah. What?
That would be more than they're doing.
Does anybody know anything about that?
Well,
It's
Is
not
that
that.
Is that a typo? I don't understand.
Nope.
145%.
That's what they said. It's
Yeah.
well,
Of the hospital expenses. How do you do that?
Well,
Well-
what happened is private insurance is subsidizing the rest of the system. So if you review, you're just, you're not spending more or less money if
okay.
you change the system particularly.
Uh-huh.
You got hospital expenses, they're getting more from private insurance than from Medicare. Well, fine. They've got $50 million to work with this year. So it's going to be from single payer instead of from the separate
Yeah. Yeah.
insurers. And then they wouldn't have, and out of the other comeback on that is their overhead to collect from the insurance is how much? At least 10% of what they're collecting.
Oh, yeah.
You
And
know,
how many
5 to
staffers,
10%,
how many staffers do they
yeah, well,
have
that's
to employ
overhead. Yeah, I mean, they're,
to do
no.
that? Right, well,
and
that's
They
good.
also won't have any uninsured people who pay nothing,
Uh-huh.
and they won't have any Medicaid people who pay at a lower rate than Medicare. And they will have global budgeting, which meets all of their expenditures. Every
Mhm.
hospital will have sufficient funds to operate.
All right. Well.
So the 145% is because they're not just paying for Mrs. Smith, they're paying for Mrs. Smith and the uninsured.
yeah.
Well, that's what it's
Right.
going, well, they put the figures this way, The private insurers are paying higher rates, although not always. Sometimes they bargain and are paying down,
Uh-huh.
That's why you gotta use a certain hospital because they've got a deal with
Right.
that hospital.
Mhm.
So it's not always that way. But the hospitals are gonna be totally well-funded under
Mm-hmm.
Global.
a single payer plan. Everyone says that,
All the hospitals,
all of them.
not just the ones in a big urban area,
Right,
Mm-hmm.
Oh, right, protecting the rural hospitals.
protecting
too.
rural hospitals.
right.
We could even keep our hospitals in eastern Kentucky.
Yeah. We could have one in the south end, maybe one in the west end instead of all in the east.
Yeah. Which is a good argument.
Well, and that current AMA president is like my eye doctor who's
Yeah.
saying he's not being reimbursed. And that's the one thing, for example, in the Canadian system, doctors are adequately reimbursed. And I mean, they have boards that set those figures, and they're not politicians that are doing it.
Mm-hmm.
But here's the other thing. You don't have to fight the damn insurance companies to get paid for it. We only have hundreds of corporate insurance companies where you have to fight. It has hire people just to fight the dogs
Mm-hmm.
to get money out of them. All you have to do with Medicare is just wait for the money to come in.
Mm-hmm.
Right, but a doctor should be properly reimbursed.
But
Well, they
the-
should.
The salaries of the Canadian physicians are really good. They're comparable to ours. I think there's something like 200,000 to 500,000. The
I
range.
think for
is
primary
not-
care, better than US.
It's better, really.
In primary care, they're
Primary
better.
care, Yeah.
Oh, there you go.
Okay.
Even Great Britain, a horrible socialized medicine, the average doctor makes hundreds of thousands of pounds a year. So,
So then I went to this first myth that they talk about this, the Himmelstein Woolhander article about how most people think that private insurance funds the majority of healthcare, but actually, if you would look at the health insurance for government employees and the tax subsidies for employers to provide coverage, it actually ends up being 2/3% is tax financed, which
Now, right.
yeah, which would
Well, that's interesting
mhm.
because, well, we always show that chart that shows how much the taxpayer is already paying, how much is already publicly funded. So that's Medicare, Medicaid, and also the VA and the Indian Health Service and
TRICARE and the city and state governments
yeah,
paying for their
employees, etc. And but this is interesting. I've never seen where they've added the subsidies
Mhm.
that are going to the taxpayer subsidies that are going to help people who are buying the private insurance plans in the ACA. Isn't that what that's about? Government? No, where did I just read that? I thought I just read
The
that about subsidy.
tax subsidies at the bottom.
Yeah,
Yeah.
right.
Sarah, does that 64.3% include employers? Or is it just taxpayers?
I think they just mean taxpayers.
Okay.
It's the
Or
it's
Katie
the
and
overall healthcare spending in the whole country. 64% is paid by some form of government money.
Which is taxpayers,
Yeah.
Yeah, it's either
so it'd be,
cities buying healthcare or states buying
Mhm.
healthcare
Or
or
individuals?
your individual Medicare premiums.
No, it's not individuals. This is government money that purchases healthcare.
Maybe it could be the taxpayers, the companies that get deductions because they have to provide health care insurance. to
Well, that's the
employees.
second point, is that the all of that is a write-off. What employers pay into healthcare
Mhm.
takes away taxes because that's non-taxable.
Yeah.
So that's added in,
Mhm.
is that write-off.
Another advantage to me is that I wouldn't have to fill out medical expenses on Schedule A.
Mhm.
Well, that's interesting.
So then I just went to kind of looked at the different studies and started off with how much we're currently spending, which is 3.5 trillion, and then the amount that employers spend to administer the health insurance plan is 32 billion, which is very
This
high.
is what they spend to administer.
Mm-hmm.
That's interesting. So that's the employees they have in human resources that manage their employee health care. Must be.
Yeah.
Like every big company has a human resources department that wheels and
It's
deals.
actually employer cost.
The cost of how much the plans cost too.
Monday, the administration
Yeah.
is separate.
Yeah.
Oh.
Mm.
To administer.
Do you know where that figure's from, Sarah?
I thought I took it from the Pollen study. No. I may have been in the Friedman study. I'm not sure.
Well, that would be interesting.
But then there's also that study that says that the Japanese spend half as much as healthcare and they go to the doctor 3 times more. That's in the in the Fix It video, and then also the quality measures that we
don't have.
Yeah. Don't rank very well in comparison to the others.
That's a really important point because those who oppose single payer try to build the idea that healthcare will be rationed, that we won't get to go to the doctor, we won't get to
Mm-hmm.
we're going to be kept out. And when we show that,
Yeah.
Mhm.
other countries go to the doctor more and they have more days in the hospital.
Mhm.
Doesn't show a
And they
ratio.
don't have much, many of those countries don't have any worse wait time than we do, if even less wait time.
Hmm.
For some of us, wait time is never.
Yeah, well, there
Well, I
you
have one
go.
more thing. Wait time is not a problem if you're well off and affluent. If you're poor in clinic, or you know,
Well,
you
we
gotta
don't get
wait.
high quality.
Okay.
That was a
Then I went and looked at specifically at these studies and looked at some of the numbers involved and the cost there from the Friedman study. The cost of the transition to a single payer health care would be 39 billion. They said, but we would have all the administrative waste cut. We would reduce the pharmaceutical prices by having bargaining power of one single system. Everyone would get coverage. No one would have copays or deductibles. And then it said that the reimbursement rate would be equal to the Medicare rates right now, which we've already talked about that a little bit. But I feel it's hard. Like you were saying with your eye doctor, it's hard to tell someone to explain to a doctor how much they would reimburse, and you say, oh, they would be equal to how much Medicare is now. Well, they don't like the way
No,
Medicare is
that's not
reimbursed right
enough.
now.
Yeah.
They say it's not enough, and so it's difficult to say what the reimbursement would be.
Right, they're
Well,
saying
but-
they'd increase Medicaid up to Medicare's rate.
Mm-hmm.
But Medicare will set a rate that is works, in other
Mhm.
words, to keep, make sure we
Mhm.
have doctors in it. And they won't have the Medicaid at a lower rate.
Yeah. Yeah.
And they won't have the administrative costs in their offices. And they
Mm-hmm.
won't have an insurance company bugging them.
Yeah,
And they will be able to set up independent shop, which you can't really do right now.
that's true. Yeah.
Set up independent what?
If you're a single,
Yeah.
if you just come out of practice, you want to go practice and open.
Oh,
up,
yeah, yeah.
You can't. I mean, it just
You can't right
doesn't
now.
work.
Oh,
You know,
okay,
just the way the system is now.
right.
Mm-hmm.
And they will get paid.
They'll get paid.
Yeah.
That's right.
And then, so this cost of transition, I went to the next that shows how we would get that money, and it adds it all up from you'd have reduced hospital and doctor administration. This is number 7 for y'all are looking. The reduced overhead from only would save a lot of it, and then also the insurance overhead from having cutting out all the other insurance companies, and then also the savings on the pharmaceuticals would more than enough save to be able to fund the transition.
I tell you, pharmaceuticals are so awful now for like diabetics, etc.
Mm-hmm.
Like $1,000 a month.
Mm-hmm.
Okay, so now you get to the taxes.
Yeah, but then it talks about the new progressive taxes. Yeah, there's a chart. There's a lot of different taxes, but mostly it would be
Affecting the welfare.
yeah, for the most part.
Yeah, he's got a lot of categories in there, but his point's well taken.
Well, I like the fact that this is definitely going to reduce income inequality. Like the $53,000 income, if you're over it, you're going to be taxed 6%, and under,
Mm-hmm.
it's going to be 3%. And that alone would help on income inequality, and that's one of the basic problems in our country.
Mhm.
Mm-hmm.
Right, this is the HR 676 scheme.
Mhm.
Well, it's Friedman's.
This is Friedman was looking at
Mm-hmm.
the outline laid out in 676.
Yeah, but I think he did this in 2014, and medical expenses are just rising. So,
Right.
you know, it's gonna have more of an impact than even what he said, because the cost of medical treatment's rising.
So with the new bill, is all of this in there too?
No, there is no funding scheme.
Okay.
None at all.
And
But this
Bernie
was-
hasn't done it either.
This is a model, I guess.
Well, I think it was a good model
Yeah.
Yeah.
because it tries to make it a progressive tax. Certainly the stock and bond thing hits only the people who trade on the
Uh-huh.
in
Well,
good money,
And they must have looked at the Canadian or looked at Taiwanese.
and it tries to keep the taxes modest so that it's not a burden on the active economy on workers and employers.
Mm-hmm. So that goes to the number 9, where it's a breakdown of what, for your household income, how much you would pay in taxes for this health insurance. And then the next page compares how much it currently costs, which the current average premium for family coverage is $18,764 per year, which is a crazy. I think that was based on like an income of 50,000, 50-something thousand. This was from the Kaiser website, I think.
And that's
That is
employer and
just-
employee, correct? That 18,000.
Yeah. Yes, I think so.
Right, yeah.
It's an
It's
average
like
premium.
10 and 8 or something.
I think it breaks down.
The numbers are really tiny down there.
To 12 by the employer and
12.
6 for the
Okay.
6,000 for the employee, but that's just the beginning of what the employee pays.
Yeah.
Because then they have a $6,000 deductible and they have the out-of-pocket expenses. And
Mm-hmm.
You don't think they want to see single payer?
yeah, that
Yeah.
employer-based insurance is getting worse
It's getting worse.
Yeah.
and worse and worse.
Mm-hmm.
And fewer people are covered. And there's even this study McCann put out that lower paid employees have even just terrible coverage.
Yeah.
You know, the people who are at the bottom of the scale.
One argument we can make wasn't one of the Japanese auto firms, I think it might have been Mitsubishi or one of them, opened a new plant in Canada. Now, wages there actually for auto workers are actually higher, but they moved there. Reason? Healthcare. Or they even say expenses per worker were lower. Well, what are expenses,
Yeah.
Healthcare.
Healthcare, you're right, benefits.
The other thing employers are doing now, or the insurances are doing now, is if the spouse works for another company that offers insurance, well, tough, we're not covering you.
Oh, yeah,
Oh, wow.
right.
Really?
Say that again. If the,
Well, it used to be, and I don't know company by company, but if you work for Ford,
Your
or
family was
you
covered.
put your family on there, no problem.
yeah.
Now, your family works for something, your wife works for someplace, or the husband works for someplace else. They don't want to cover them.
And they don't have to. right?
And they don't have to. And same thing when you show up at the hospital, they ask if you have insurance, if your spouse works for somebody and all that.
All right, then next I took the pollen study, which is Bernie's Medicare for All Active 2017 study. And it shows that current spending is 3.24 trillion, and then with Medicare for All, it would be spending 2.93 trillion with his bill.
Which one is this?
Number 11.
Number 11.
At Bernie's, apparently. Was it Bernie's?
Yes, this was Bernie's.
This is the pollen
Yeah,
study?
yeah.
Well, I have to say this.
What?
Pollen didn't actually study Bernie's bill.
Oh.
He pretended he was studying the Canadian system because there is no global budgeting for hospitals in the bill, which would save a bunch of the money. And therefore, the savings are exaggerated if they're applied to Bernie's bill. And Bernie has repeated that in the new bill, which he just introduced in the past week or two, which is to keep the value-based payments and the pay for performance, the accountable care organizations, which is a backdoor for the insurance companies. And so the Pollen study is a good study, except if you say it's for Bernie's bill, it's an exaggeration of the savings.
Okay, so it's really just studying Canada's system.
He
Well, and-
studied Bernie's bill except for the global budgeting.
Do the
Oh.
Canadians have global budgeting?
Yes.
Must be bright then.
Yes. So he kept and that's the mantra from the ACA is this value-based payments, pay for
Yeah.
quality, pay for performance, bundled payments. It's 10 or 11 things that are included in that, which unfortunately he again put in his bill.
But why is that so? Why are those things so tied to the insurers?
Well,
Because they require more administration.
Yeah.
they require
Yeah,
a lot of
It's
administration.
it's adding overhead. It also doesn't, I mean, from a physician's standpoint, pay for performance, what's that really mean? If you don't jump through this loop, this loop, this loop, and
okay.
document, we cut your pay. That's what pay for performance is.
Yeah.
no.
Okay, and it's not really demonstrated to improve overall healthcare or outcomes or stuff, but it sounds good. You
Yeah.
know, you can sell it as, boy, we're doing something good for the consumer because we're doing pay for performance.
I thought that was about measuring outcomes.
Yes.
Mm-hmm.
Every
But it's-
time somebody comes in for, let's say you came in and got a pneumonia, okay?
Okay.
So it's two ways to measure outcomes. How did everybody do that came into this hospital or doctor with pneumonia? That's one way to look at it. Keep track, score the doc. You're good, you're bad, let everybody know. That's simple, okay?
Okay.
We're gonna score by procedures. What time did you give the antibiotic? Which antibiotic did you give the proper antibiotic? Did you do a blood culture? How long were they? I mean, all these little things. These are data points. Everybody got to take time to fill these all in. Okay, so they're saying if you did all the if I did all these things right and filled in all the blanks, it took all the time to do that.
Okay.
Okay, and my pneumonia patients did no better than average. I get paid more. I mean, really what happens is if I didn't fill in all the blanks, because I'm a little private guy out in Hopkinsville, Kentucky, and I didn't have the computer systems to do it, I got my pay cut by 20%. I'm at the same outcomes,
And you see
but I
the-
didn't do all the documentation. They look by documentation of process, not
Okay.
outcome.
Well, they're pretending that they're measuring the value and paying by the value, the quality.
Yeah.
But the problem is, all the studies show that the doctors who serve Medicaid patients, poor people, Black people, they have worse outcomes. Not because they're worse doctors, but because the conditions that their patients deal with in life, their nutrition, their whatever else is happening in their lives, means they don't have as good an outcome. So it's punishing the doctors who serve the African American and the poorer communities, and it's not improving things, and it's causing the burnout because it makes you meticulous, computerization of every point because they're using this supposedly to evaluate the doctors. And it's horrible, and it doesn't allow us to save that money, and it also is a backdoor for the insurance companies because it makes the doctors and hospitals take on risk, and risk by its nature is insurance.
Well, hasn't that been abused also because then they upgrade that's a bad word for diagnoses. So they.
Upcode.
Oh,
Yeah.
you had a pneumonia, you know what? You had diabetes, your sugar was 101. I'm putting in diabetes 2 for diagnosis.
Yeah,
Mm,
yeah.
I get paid more.
yeah.
Oh,
So the upcode, all of that will
Yeah.
remain in the
Yeah.
system if we don't take that out and globally budget the hospital and say, we're gonna pay the hospital what they need to run
Yeah.
to take care of the
It
patients.
just,
they
and
have.
you know, the quality issue, it's a real issue. Everybody ought to care about it.
Sure.
Publishing outcomes and transparency is simple.
Mhm.
You don't have to have people have
Okay, yeah.
32 data points, but
Yeah.
you know, it's okay to ask how many of my patients died of pneumonia when I took care of them at the
Mhm.
you know, U of L hospital. And people can make judgments.
Mhm.
You know, probably the Cleveland Clinic has a higher mortality rate with pneumonia than a lot of places. They get all the transfers of shock and terrible patients, and but people can make judgments about
Mhm.
you know the quality of care. But it's just transparency of what's going on. You don't have to have the insurance companies involved.
This was we did a case today, like, you know, so and so patient comes in and they have trauma. They end up getting a hospital acquired infection, and you know, they're telling us all this, what happened. And because they got this hospital acquired infection, Medicare will not pay for their services because it was the fault of the doctors. And then they find out at the end that because the hospital was in the top 25% of having hospital related infections, that they're going to cut the hospital's pay 1%, which meant they had to lay off all these people. This is a case that they gave us to learn from about.
wow.
So
About how this works.
yeah, about how it all
Well,
works.
there's been this big thing, you know, they put into this payment system that if the patient returns in 30 days after the
Yeah.
hospital's discharged them for congestive heart failure, then the hospital doesn't get paid when they come back because Medicare doesn't pay. But they're punishing them. Supposedly they're saying that the reason for the return is that they did something wrong, which is not necessarily the
No,
case.
because heart failure,
CHF,
congestive heart.
Well,
it's
I-
nature, it recurs.
I had a 92-year-old with flu who was throwing up, vomiting, low blood pressure, went in the hospital, got a couple of days, got rehydrated, went home. I saw him in the office. They're still throwing up. They still got diarrhea. Their blood pressure is low. Guess what? We send them back to the hospital. You think they're going to get readmitted, which they need?
Oh, they wouldn't
There's
readmit.
a higher bar. That hospital does not want to readmit them.
They don't.
Oh,
They get
my
big
They're
time
God.
ding.
punished.
That's
Yeah.
the kind of story
Yeah,
that
And
this
needs
that's
to
you
get
get that kind of
out.
disincentive, which is,
Mhm.
That's
bad
pay
for
for
medical care,
performance.
yeah.
Value-based payments.
Sounds like crap to do in schools, that's our subject.
Bad
Over
stuff.
Yeah, well, I'm glad you
Test everybody
explained
but
some
the
of that
assholes
though,
on
because I
top.
didn't understand that.
But it also costs us more because it costs so much administratively.
yeah.
I guess I didn't realize a hospital can decide whether or not to admit a patient. I guess I didn't realize that.
Because
Well,
they
the-
will get penalized for this reason, the standards for them to readmit is
Well,
even
the
higher.
doctor in the ER is making the decision.
In the ER.
But not without pressure.
Got a hospital budget. I just heard about this case, and they must say, hey, we're getting our budget cut by 1%. Here comes another one. Well, let's just try to do this and this and scoot them back out the door.
Well, I think we're out of time. And the
Yeah,
Paulin study is it's 200 pages and it's not even right. So.
Well, part of it is right.
I didn't read all of that. I'm sorry.
Well, not everybody's saying that. But if you look at the
Well,
David and
Did you call them on it, Kay? You need to get in touch with Paul.
well, you
and
know,
tell us.
nobody's listening, and Bernie's not listening.
Does Bernie's bill have global budgeting now?
No.
It doesn't,
No.
because I was reading it the other day and it said something about global budgeting when I was looking into this.
Did he?
Maybe
If
He
you look
had
at
it way back,
I'm gonna
I
put-
think.
Oh.
But his 2007